Lauren, how have the reimbursement rules changed, and how can orthopedic physicians take advantage?
Great. Thank you so much for the opportunity to speak with you all today about reimbursement and how the landscape has changed over the last 2 to 3 months. I am going to share some slides. So, I thought the conversations this morning were really wonderful. I'm hearing 3 kind of common themes here. One around, care coordination. Both within the care settings and then with our patients as well, that we are kind of managing, remotely over the past couple of months, and really trying to identify if they're ready to kind of come in for surgery. And then the second theme is really around kind of this concept of telemedicine, telehealth, and also reporting of the conversations we're having with our patients. And then the third, concept I'm really hearing is how are we kind of managing those comorbidities before patients are really able to, kind of come back in for their procedure. So one thing I did want to highlight this morning was that, and one thing we didn't really talk about over the last 2 classes was that the AMA is really dedicated to this whole kind of new frontier in medicine with digital medicine. And in 2018, they actually more 2017, they did pull together a digital medicine payment advisory group. And so the AMA has a wonderful kind of resource for telehealth and great sections that really speak exactly to different coding scenarios, as well as different questions that have come up over the last 2 to 3 months. So I encourage you all to kind of check that website out for further questions. But, one of the big questions right now is kind of, what can I be doing until we kind of get back into the swing of things and do start performing some of these elective surgeries again. And with the 1135 waiver that was passed in March, one of the big things was CMS is no longer enforcing a requirement that patients had to have an established relationship with the physician in order to provide telehealth services. So what does that mean? That means that you can actually now bill E&M services if you feel like you're having, a more in-depth medical decision-making conversation with your patients from your own home. So that also opened up the ability to bill place of service 11 from your own home as well. Now, if you are providing a telehealth service, you would indicate place of service 2 for telehealth, and then you'd actually also append modifier 95 to the coding that you have chosen to use. And we're going to go through those in the next couple of slides. The other thing this 1135 waiver did was it really opened up the utilization of different modalities, right, to perform these telehealth services. So FaceTime, Zoom, Skype, different communication services that allow communication with your patients. It does have to be audio and visual. So that's one thing to keep in mind, but HIPAA should, although it's always a concern, it shouldn't be your main concern at the moment. This 1135 waiver was really passed so that you had the freedom to, really communicate with your patients and make sure that they are, doing the most that they can to maintain their health. So this is just a quick snapshot of the kind of E&M codes versus, some of the telehealth services that are being performed. Now, one thing that the 1135 waiver also did was it introduced this concept of total time of services provided and medical decision-making performed on the day of the encounter. And it introduced this earlier. So this concept was set to be introduced into E&M coding in 2021. And the 1135 waiver, basically bumped this up by about 9 months. So keep that in mind when you are coding for your interactions with your patients, but the total time of services provided is going to be a new concept that will be implemented, that is being implemented now, and that will definitely be implemented in 2021. G-codes were established to describe telehealth services in 2019, and they'll continue to be utilized going forward. Again, as I mentioned, place of service 2 should be indicated and that modifier 95 should be used. I think as you're thinking, when I'm thinking of the conversations we just had with Dr. Zuckerman and Dr. Barnes and Dr. Zarzer and Bill, think about the different interactions you're having with your patients as you're kind of monitoring them to come back and have their elective surgeries. Many of those conversations can be billed. And if you are incorporating some type of medical decision-making or consultations, those conversations absolutely should be coded and billed out. Now, another concept that we really kind of brought to the forefront with COVID-19 was remote patient monitoring. So remote patient monitoring really was pushed into the forefront in 2018 with this digital payment work group at the AMA. And really the concept came out from, really kind of your blood pressure and your glucose monitoring and those devices. So if you think of kind of, the Medtronics of the world that have your diabetes monitoring devices, that's kind of the genesis of this coding set. CPT code 99091 was one of the first ones to come into existence. And then in 2019, we saw the addition of 3 codes as well. Now, one quick fact with remote patient monitoring, there was a technical correction to code 99457, which will be important for you all. This allowed for incident to billing, meaning that nurses and licensed care managers can now provide these services and are able to bill out for them as well. So think about that as you're kind of delegating or managing your patient flow right now in kind of evaluating whether that patient is ready to come back for surgery or not. This is just a list of some of the codes that can be used for remote patient monitoring at the moment. If you think about it, blood pressure, cuffs are available at Walgreens. I've seen a lot of pulse oximetry monitors actually on Instagram being pushed. So a lot of these devices are really being used currently right now, and we have the coding sets in place currently. So we kind of discussed on restarting essential healthcare services. There was guidelines kind of shared by CMS on April 19th. I think we need to think about that as well. But, the big thing here is that digital health is really going to most likely expand post-COVID-19. And I think the more we can think about how we are adopting these programs within our practices now, the better off we'll be. And in particular, your specialty has such a large voice in the community. So the more you can think about how these programs can be adopted within your current, practice algorithms, and how you can communicate that back to the AMA and the CPT panel, the better off your specialty will be. And obviously the goal is to make sure that our patients are ready and healthy enough to think about getting surgery again. So thank you very much, and please reach out with any questions.